Thank you very much for the kind invitation to talk about pharmacology of injectable antiretrovirals and the implications for toxicity and resistance. These are my disclosures. So just to introduce the topic of pharmacology of long-acting, obviously, when we look at the concentrations of long-acting agents in the systemic circulations, the shape of the curve is quite different than the curve that we see following the intake of oral daily antiretroviral drugs. And you can see that the main PK parameters and concepts around pharmacology remain the same. The concentrations need to be above the minimum effective concentrations and below the maximum safe concentration. So it's very important to achieve and maintain over the dosing interval, which is obviously prolonged, therapeutic concentrations. And here you can see the concentrations of cabotegravir and rilpivirine, two available, or at least available in some areas of the world, long-acting antiretroviral agents that are administered in combination for the treatment of HIV. You can see the concentrations in people who took part into phase 2 and phase 3 studies like Latitude and Atlas and stopped the cabotegravir and rilpivirine injections. And you can see the long-term persistence of the concentrations. Please keep in mind that the x-axis is months rather than hours, which is what you're more used to see when we look at the PK graphs of HIV treatments that are given daily orally. And this is consistent with the prolonged half-life of cabotegravir, which ranges between 5.6 and 11.5 weeks, and the long half-life of rilpivirine, which ranges between 13 and 28 weeks. What it is also important for us who would prescribe or administer long-acting agents for the treatment of HIV is the knowledge about drug-drug interactions. And the good news is that there's not many drug-drug interactions we need to remember for cabotegravir and rilpivirine because they are not perpetrator of drug-drug interactions, and they can be victims of some few interactions. So co-administration should be avoided with strong inducers of cabotegravir and rilpivirine metabolic pathways, which are mainly UGT1A1 and cytochrome P453 respectively. So we should avoid co-administration with anticonvulsants like carbamazepine or phenobarbital or phenytoin, or with antibiotics such as rifampicin and rifabutin, or chronic high doses of dexamethasone or St. John's wort. Other interactions to remember is to be cautious about the co-administration of rilpivirine with erythromycin, clarithromycin, and azithromycin is therefore preferred, and also clinical monitoring is recommended when long-acting cabotegravir and rilpivirine are taken with methadone. So you can see the number of interactions to remember is limited, and this is really important in case we need to start antiretroviral therapy orally following the discontinuation of long-acting cabotegravir and rilpivirine. Because cabotegravir and rilpivirine are non-perpetrators of drug-drug interactions, any other antiretroviral can be used to cover the PK tail following the discontinuation of administration of the long-acting. So you can see what happened to the people from the phase 2 and phase 3 trial who stopped the long-acting. They took any possible other agent in combinations with NRTIs. Now, this is slightly different than the oral bridging. So the oral bridging is very important in case people who are stable on long-acting treatments are late for their next injection for more than a week. The long-acting treatment has 1 week before and 1 week later as a flexible interval to receive the next injection. And if this is not possible, the oral bridging should be initiated, and the first dose of oral bridging should be taken on the missed target treatment date. Now, importantly, the oral bridging can be taken up to 2 months. It involves 1 pill of cabotegravir and 1 pill of rilpivirine. And after the oral bridging, the injections can be restarted. Now, if the appointment is less than 1 month late, the injections can be resumed every other month as they were taken before. And if the appointment for the next injection is delayed by more than 1 month, it is important to reinitiate with the loading dose. But this is something quite straightforward, but that we need to be aware of, because it's very important to ensure that we don't leave people on injectables on concentrations that might be below the therapeutic target. Now, in terms of pharmacodynamic and efficacy data, I'm sure you're aware of the clinical trials that led to the approval of cabotegravir and rilpivirine long-acting. And we are aware of the ATLAS study that compared monthly cabotegravir and rilpivirine to daily oral antiretrovirals, and the ATLAS 2M studies that compared the intake of cabotegravir and rilpivirine monthly versus every other month. Here you can see the results of Atlas 2M in the context of virologic suppression every 2 months, when people were assessed at 48 weeks and 152 weeks. Very importantly, a multivariate analysis has been conducted both at week 48 and in week 152. This slide shows the results of the latest MVA analysis presented recently at HIV Global that has underlined the importance of certain baseline factors, such as resistance-associated mutations to rilpivirine, HIV subtype A6, A1, or a BMI higher than 30 as being more likely to be associated to confirmed virological failure. And it is when 2 or more baseline factors are together that the risk for virological failure is higher. So this is really important for us prescribers to remember. And it seems to be even more important than the concentrations of rilpivirine and cabotegravir that are measured later following the initiation of therapy, which of course are really important. And this is why I would like to underline the importance of making sure that the injections are conducted properly and the needles reach the muscular mass where the drug depot is formed and where the drug is released from. This slide shows the results of a study that was presented at ID Week very recently, and importantly, virological response rate at week 96 on cabotegravir, rilpivirine, long-acting dose either every other month or every month were similar in different ethnic groups. There was no difference in terms of virological response in white, black, Asian, or other ethnicities, which is really important because it means that the achievement of therapeutic concentrations is similar across multiple ethnicities. In terms of real-world implementation studies of injectables, we have data from the Carousel study, which is a hybrid phase 3 for implementation effectiveness study. And very importantly, the virological results of the Carousel study show high rates of virologic success, which is in accordance with what it was presented from clinical trials. And the most common adverse event was injection-related reasons that led to withdrawal in real-world data in 6% of participants, which was slightly higher than what was seen in clinical trials, where 2% of participants discontinued because of an injection-related reason. But we have seen that the side effects seem to improve over time when people are stable on injectables. In terms of other potential side effects, they were rare. The results from the clinical trial show that cabotegravir and rilpivirine long-acting are well tolerated. And interestingly, again, at the recent Glasgow conference, data on neuropsychiatric adverse events were presented, showing very low rates of nervous system disorder and psychiatric disorders in people on cabotegravir and rilpivirine through week 48. Which is very reassuring for people living with HIV who are interested in being administered injectables. Also at Glasgow, they looked at the rate of blips in phase 3 studies of cabotegravir and rilpivirine long-acting up to 152 weeks of therapy. And they looked at Atlas 2M and FLAIR. And interesting, the proportion of participants with RNA blips, target not detected, and HIV RNA copies below 2 was similar between people who took cabotegravir and rilpivirine every other month or every month and people who took oral treatment. And importantly, blips alone, while on cabotegravir and rilpivirine long-acting, do not identify those at risk confirmed virological failure. This is really important to reassure both physicians and people living with HIV that there is no extra concern about blips. Finally, a few words on another new long-acting agent under development, which is the capsid inhibitor lenacapavir, and it is a long-acting subcutaneous drug, and data from heavily treatment experienced people have shown that the can be beneficial for people with very limited therapeutic options. And you can see here the rates of participants, study participants with an undetectable viral load at week 52. Interestingly, when we look at the concentrations of long-acting lenacapavir for the treatment of HIV, a high number of people who took part into clinical trials, we see that there's no dose adjustment needed for lenacapavir, depending on people's intrinsic and extrinsic factors. So you can see that highly experienced people and treatment-naive people don't have different concentrations. Weight, gender, age do not affect the concentrations of the long-acting lenacapavir agent, suggesting that when a dose is selected, this would be therapeutic for the majority of people. And you can see here that the concentrations of lenacapavir are maintained above the therapeutic target for up to 6 months following administration subcutaneously. And lenacapavir can be initiated with few oral doses. And in this PK study, they actually tried to initiate lenacapavir after 2 weekly oral doses, so an oral loading dose following by an oral dose a week later, and then starting injections. And this is what happened in the clinical trials, but also they're proposing in oral loading dose together with the first injections, so that people can start receiving injections as soon as possible when they decided that this would be their preferred treatment. Obviously, lenacapavir still needs an antiretroviral partner characterized by a prolonged half-life that can be administered as frequently or as frequently as twice a year, every 6 months. So to conclude, in terms of key points of injectable antiretrovirals, these are definitely a very exciting tool for the treatment of HIV infection. We nowadays have results from clinical trials, but also from implementation studies that show that it is indeed a feasible strategy. And we saw that the most common discontinuation are due to injection site reactions. However, these are still rare, and we are well aware and knowledgeable about the baseline factors and the multivariate analysis that leads prescribers into administering cabotegravir and rilpivirine every other month to people without certain factors that are associated to confirm virological failure. And then obviously we have a new options, which is lenacapavir, which hopefully will be available in the near future. Thank you very much for your attention.